today, one of our really, really good friends, Miss.
It's Ashli Gibson. She's a psychiatric mental health nurse practitioner here in Wilmington, and she specializes in perinatal, reproductive, and women's psychiatry.
Nice. We had to read that, even though we know her very well. That's a lot of things that she does.
It's a lot of things that she does.
Before this, she was a midwife. So she is a treasure trove of knowledge of all things, honestly, women's health, but specifically women's mental health. So we covered. I did a lot of listening, which is good.
You asked some great questions.
But tried to ask questions that just from my perspective as a guy, that I try to be informed about, as much as I can. But honestly, I think even like what you've said, like as a woman, there's a lot that is just unknown. So
yeah, there's a lot that we don't know about our own anatomy and medical health, and women's mental health is something that is coming much more into focus and research. So it was, I learned not as much as you, but a whole lot myself.
Yeah, we covered a lot of ground, and then we ended. So I turned off record, and then we started having this very casual, candid conversation around this is where I was certainly listening, around like the pelvic exam process for a woman, and just how incredibly uncomfortable and just awkward and invasive and archaic. And yeah, so we turned it back on and rehashed that one out. So we're going to toss that in somewhere in this episode, whether it's at the end or I'll sandwich it in, but
it has a place in everyone's dinner conversation.
Yeah, exactly. We do talk a little bit about trauma and how trauma can affect, both partners, if there are two, within a relationship. So, not necessarily a trigger warning, but just something to be cognizant of, that as you go through and listen to this, that we do have actually some pretty substantial conversations around trauma and trauma-informed healthcare. But without further ado, we have Miss Ashli Gibson. Right. Well, welcome to another episode of Tell Us More About That. I am Tony.
I'm Jen.
And this is Jen. And today we are blessed with the lovely presence of Miss Ashli Gibson, one of our really good friends. So yeah, pretty exciting. We've been waiting for this one for a while. So Ashli, thanks for joining.
Of course.
Cool.
Yeah.
Well, welcome to the podcast. I'm going to have you introduce yourself. Obviously, we know you very well, but to the masses, which I will say, I don't know when this will air, but we launched our first episode and we've had over 200 people that have downloaded this thing and listened to it, which is kind of fun for one episode.
That's amazing.
Yeah. So
kind of scary.
Yeah, I mean, who knows? It's probably like my mom and your mom, 100 times each.
Yeah.
But yeah, over and over. But yeah, before we get into your introduction, we've kicked off every episode with a really important point, which is Jen asking a very important question.
So my friend a long time ago gave me a conversation starter game. And so we just kind of randomly pick cards from there, and we just ask the question to our guest of honor. So our question today, Ashli, is which celebrity would you like to see at our local bar? I say "our" because
I feel like that's probably like the worst. I'm like the human being who pays no attention to like celebrity news or gossip. Oh, that's a really good question. You know what? Now that could be a really good one. You know what I love? I love Brandi Carlile. I think she'd be super interesting to talk to. She's written a book. She's done a lot of activism, and we've seen her a few times in concert. So that would be great.
Oh, cool.
That's a really good one.
Yeah, I did not know she had written a book.
She has. It's really good.
Yeah, I've seen her in concert a couple times. She went to, I saw her at Highwater.
Mm-hmm.
You go to Highwater, don't you? Are you used to?
I don't. I've seen her a few times at the Newport Folk Festival. She did a set with Dolly Parton, and then she's been such a big, intricate part of Joni Mitchell coming back and performing. So I got to see her with Joni Mitchell. It was like life changing.
Oh my gosh. Yeah. That's awesome.
Yeah.
That sounds amazing.
Okay. That's a good one.
That's a great answer.
Yeah, that's solid. All right. So let's go with an introduction. So who are you? What do you do? What's your background? Please fill us.
Yeah, so I'm Ashli Gibson. I'm a certified nurse midwife, and most recently got certified as a psychiatric mental health nurse practitioner. My path getting here was a little bit winding. Healthcare was never my excuse me, was never my initial career. I have always been interested in mental health. I have a bachelor's degree in psychology. Thought I wanted to be a sex therapist, so I've also always been interested in reproductive health as well. But in school, I also got really passionate about Spanish. So I got degrees in psychology and Spanish, and my first job out of college was at Planned Parenthood as a translator. There I worked
Wow.
there I worked under a midwife and really fell in love with women's health and went back to school to get a nursing degree and then master's in nursing as a midwife.
Wow. So I will say too that while we know you well, we also don't know like a lot about you in terms of this journey. So that is really interesting to learn.
Yeah. Yeah. A lot of times going back to school.
So you mental health though, kind of the whole way around. I know you said you kind of worked your way into it, but like I'm sure, well, you can tell like the draw to Spanish and then using that skill in a place like Planned Parenthood. What was it that you were kind of going after there?
So, to be honest with you, we graduated in 2008, both my spouse and I, which was not a great time to graduate college. And I was pretty desperate to find employment and happened to have a connection at Planned Parenthood. So, I would love to say that this was really intentional, that I wanted to be somewhere that I was passionate about, but it just happened to be the first job opportunity that I had. And it was such an amazing match and fit.
That's wild. So at Planned Parenthood, was that where you were working under a midwife?
It is. Yeah, I worked with
Okay.
OBs and a midwife, but worked really directly with the midwife.
Yeah. How long were you there for?
So I was at Planned Parenthood for about 3 years.
Okay.
And then at that time, my spouse and I moved to Costa Rica for about 6 months to a year, just with the intention of getting better at Spanish. At that time, I thought I wanted to go to med school and was studying for the MCATs. And thankfully met a resident physician in Costa Rica who gave me some really great advice that he felt like after the conversation that my values were more in line with nursing, potentially being a nurse practitioner. And that's, it's one of those moments in life you look back on that it was just one conversation that changed my career path. And I'm so grateful for it.
Was this some stranger, or like who was this person that fell into this life-changing advice?
It was a stranger. We were on our last leg of our trip. We had lived on both sides of the coast, and as our last little stint went to the middle of the country. And I got on this big hike with a group, and afterwards just happened to strike up a conversation with this individual, and this conversation was so instrumental.
Huge to you. So I get the whole like graduating into an economy that was a literal dumpster fire. So kind of taking whatever option you had. My first
Yes.
job right out of college was a pretrial officer, and it was the same type of situation. It was at a community corrections facility, and the director, when she offered me the job, she said, "Tony, this is going to sound like a lot of money to a recent college grad, but we're willing to offer you $29,500 a year." Yeah. My paychecks every 2 weeks for like $981, and I was like, "Oh my God." But it's a job.
Yeah. Just getting by, man.
Yeah,
Mhm.
it's the
Oh,
way that
wow.
it goes. Okay, so psychology's always been there in the background because was it a double major? Spanish psychology?
It was a double major. So my dad's a therapist, and I saw like his capacity to change people's lives and his kind of influence within the community, and was always inspired by that. And I'd honestly really had just intended to major in psychology, but I had a Spanish teacher who was really influential and studied abroad. And I think just being immersed in the Latin American culture and the language, I just really fell in love with it. So that kind of led to the double major.
And us knowing you and knowing kind of what your career path has been, and me feeling like a terrible friend because a lot of what you just said is news to me. So I'm like, oh my
Yeah.
God, those are amazing, amazing things. But you specifically, I feel like you've always been passionate and had a conviction towards helping women. And that's kind of where, not kind of, that's exactly where your career has led you to, in a lot of really unique kind of niche ways. But what is it that you're seeing now in your new role that even inspired you to do this new role, that you feel like there's where's the greatest need in like women's mental health that you're hoping to address?
Yeah, so like I said, I was still am a certified nurse midwife, but I worked within that capacity for about 7 years. I was in a hospital affiliated organization, attended births, did the full range of gynecology care, like birth control, pap smears. And I think the one thing that I was most surprised about entering in that career was the amount of mental health that women were coming to me, hoping to get some insight into what was going on, hoping to get help for treatment. And I felt wildly unprepared to truly be able to address that. There was some within our formal education as far as mental health goes, but that not to the degree that I really needed it. And so just over time, I got more and more frustrated because I felt really comfortable prescribing like first line medications. But if those didn't work, trying to get someone in with a psychiatrist in a smaller town who knows pregnancy, postpartum, specific women's concerns, it's really limited. I had women who were on like a 3-month waiting list, which
God.
yeah, that's really hard if you're in that spot. So I just got so frustrated with the lack of resources, my lack of education, and decided that I needed to go back.
That's cool.
That is really cool.
Yeah, and sad at the same time that like
Mhm.
you realize, I know these are two very different things, and I'm probably gonna get crucified for this, but it's kind of when you were saying this, I was like, it'd be like living in a town that has a shit ton of restaurants, and none of them are the type of food that you need. And so you have to go to culinary school, learn how to do it, open a restaurant. That's literally what you've done in Wilmington, because you're kind of
Yeah.
now the only, aren't you one of the only psychiatric nurses in this entire area?
So we do have a lot of psychiatric nurse practitioners, but as far as someone who specializes in perinatal psychiatry,
Okay,
so
yeah.
like psychiatry during pregnancy, postpartum, but really women throughout the lifespan, because like menopause, there can be huge mental health changes with menopause. To my knowledge, I'm the only one in the area that has this particular specialization.
And I think a lot of women tend to just throughout their lives kind of grin and bear a lot of the things that they go through. And so I wouldn't have ever guessed, had I not known you, that there is someone out there that specifically addressed those issues.
So the need, obviously it being there, I think what's unique, and this tends to happen in a lot of different industries where people don't know what they don't know. So women are going to a midwife, and they're expecting pretty much like a full scope care from this individual, and the midwife is only trained in, is it midwifery? I've always wanted
It
to say that.
is a
It
nice
is?
job,
Okay,
sir.
good.
Yes.
Yeah. So to what you're saying though, which is interesting, you guys got like you got an appetizer of mental health training when you went through that program, but nowhere near to the scope that you recognized that was needed. So these women are probably constantly feeling this void of like, this is all the hands-on stuff, but I need more. I need like the pre, during, after. I don't feel the same as I once did. I can only imagine. So it's unique that I think you had someone with your curiosity, your specific set of training, but also your desire to do more, like your desire to recognize people are asking me for things that I haven't been trained to do. and there's not a population of practitioners out there that I can direct them to, at least not in any timely manner. So you jumped in and did it yourself. I mean, you don't see that very often.
Yeah, well, I was just going to speak to that just a little bit in that, as practitioners, you can see people really start to see different needs and then get continuing education. So there are some midwives, OB practitioners, there's some really great certifications out there without going back and getting like a whole additional degree in something. So there are some OBs, midwives who feel more comfortable addressing mental health. One thing that I think could be really helpful for people to know is even if you have a practitioner who is more knowledgeable in these things, I think a huge constraint is the way our healthcare system is set up. So I don't know if it's always apparent to women coming in from the practitioner side what things look like. So like a routine pregnancy visit, you have 15 minutes scheduled for your entire visit. That's getting checked in, getting your vital sign taken, and being seen by a provider. If you're going in for your pap smear, that may be 30 minutes. But that's also if your practitioner isn't double booked, if they're not running late. So I just started feeling like it is completely unrealistic for me to address the pregnancy concerns, anything else that may be going on, as well as if a concern is brought up for mental health, to be able to do this in the time frame that we're scheduling. It's completely unrealistic. So I think that's a really big part of the puzzle too.
Mm-hmm.
So if I'm thinking like for mental health therapy, rather than not with the, gynecology and like women's medical issues and that a part of the session as well, mental health therapy sessions are scheduled for 30, 45, or 60 minutes. And most of the time insurance is looking for that 60-minute session. So is that kind of how it's coded through insurance with your practice as well, that insurance will cover this certain amount of time and you've got to figure out the rest of it within that time constraint?
So, I have a little bit more freedom now within the role of psychiatric nurse practitioner as far as coding goes. I've set my initial appointments for an hour and a half. I'm really only going to be reimbursed for an hour of that, but I'm setting up a private practice and I'm going to do it how I feel like really benefits the people that I'm serving. And I think we need that time, especially if there is a component of pregnancy and postpartum going on, because a lot of times women need to discuss their birth story, and there's just no way to cover all of that in an hour. So I do have some more flexibility as far as visit time length in this new role, which is nice.
Yeah, absolutely.
Yeah, that's great. So let's say you have, we're going to generalize this a little bit, but
Sure.
From what you've seen, what you've experienced, and what you've learned, what do you think are some of the more common concerns or things that surface with women around like mental health related? Is it perinatal? Can you define what perinatal is?
Man, Tony, you're crushing it, man.
What is perinatal though? What does that mean?
Yeah, so it's really just the time around pregnancy. So that could be pregnancy planning. It could be women who are experiencing infertility. There's a lot of mental health concerns, anxiety with that. It could be the pregnancy itself. It could be pregnancy loss. It could be postpartum. So it kind of encompasses the whole pregnancy journey.
Wow. I mean, I didn't even consider the infertility issues and stress into this entire conversation that we're going to have. So we'll definitely get into that a little bit too. But this is a pretty broad scope then of all of the mental health related challenges that have anything to do with getting pregnant, being pregnant, and dealing with post-pregnancy.
Yes. Yep.
Okay.
I think we're also forgetting that like women aren't coming in like mental health neutral. Not all women are coming in mental health neutral. So it might be that this new season of their life in perinatal pregnancy is bringing up more things. But if someone already has PTSD or depression or bipolar, right, we're adding on a whole nother layer to that too. So it's not just the mental health due to women's health issues, it's humans.
Yeah, and that's going to be that's dealing with people. Like it's a mixed bag, right? Which is a really good point. So maybe my question is oversimplified, but if you've got just what would the highlights be of the main things that you see of people coming in and seeking out care from someone in a position like yours?
Sure. So I think as mental health has become less stigmatized, I think a lot of people are more aware of very specifically postpartum depression, which is great because I feel like it makes it easier for people to seek help and to understand more of what's going on with those changes. But there's a huge spectrum. And I think another thing that does disservice to women and their families is that some of this terminology is really new. So like in the DSM, as far as diagnoses go, the only thing that's related to pregnancy and mood disorders is major depressive disorder with peripartum onset within the first 4 weeks, which is ridiculous because most providers agree that the postpartum period, it may go on for a couple of years, like definitely at least a year out from pregnancy. 4 weeks is ridiculous. But what we've started to realize is that perinatal mood disorders can also manifest as anxiety. Postpartum OCD is not uncommon. There's the extreme end of things like postpartum psychosis, which can be really scary, and it's pretty rare, but it is something that can manifest. But Jen, you were really on point that if people have pre-existing things coming in, it absolutely affects their pregnancy, their postpartum journey. So yeah, there's a lot of different manifestations of how this can look.
So would you recommend to someone someone who's wanting to get pregnant at some point in time to start this mental health journey with this proactively and early, so that like you could sit down with them and assess what are their current mental health challenges, how could these things manifest into something that may be scary or challenging, or just so you can kind of map them in the right direction and give as much like preventative care as possible?
Absolutely. So I think there's a couple different ways to think about this. So if a woman's on like a mental health medication already, then a lot of times she's going to want to have a conversation with her provider of what are the risk benefits of me continuing or stopping this medication. So that's a huge conversation to have. And the number of women that I saw coming in who just cold turkey stopped their medications once they had a positive pregnancy test, it was such a large amount, and it can cause such a backslide as far as mental health goes. When a lot of the psychiatric medications now, we have really good data that the majority of them are safe during pregnancy. So that would be a huge thing to consult with a perinatal specialist prior to getting pregnancy if you're on medication, just to learn, again, what are the risks, what are the benefits of me continuing or coming off of the medication. So that's a really big part of it. What we know is if a woman has a pre-existing mental health condition during pregnancy, it sets her up for a higher risk of that occurring or getting worse postpartum. So if there's already existing depression, if there's already existing anxiety, the chances of that worsening postpartum are pretty high. So that's something that we really want to make sure it's in good control during pregnancy to help set her up for a really supported journey postpartum. The other big thing here that was something that I really lacked understanding of as a midwife is individuals with bipolar disorder. There are a lot of risks postpartum for worsening depressive episodes. There's a higher correlation of postpartum psychosis with individuals who have bipolar. Again, postpartum psychosis is relatively rare, so I don't want to fear-monger about that, but it's something that's really, really important to consider.
Yeah. And I love what you had said a little bit ago, just about how we are destigmatizing mental health and we're learning new language to talk about it. And we're learning new language even in this, in this podcast with you here. But I don't think the DSM has updated in some time. Do you foresee like that shifting? Do you see this becoming more evidence-based, more kind of, I mean, you see it all the time, but do you see this happening, kind of going that direction?
You know, the field of perinatal psychiatry in general, in comparison to other fields of medicine, is relatively young anyway. And then the very specific focus area of perinatal psychiatry. I mean, I feel like this term, it even started coming on the scene like the 2000s. So this is still being recognized, the importance of it. So as far as like changes within the DSM, I don't know, but I do know that within the field of women's health, it is becoming something that is much more talked about. I mean, it's the leading cause of maternal mortality. Suicide is postpartum. You know, you think about other things like preeclampsia or postpartum hemorrhage. It's not the physical things. It's suicide is the leading cause of maternal mortality postpartum. So it's really substantial and really important to have this focus.
Yeah. And if you're going through the more traditional birth plan, you've got your OBGYN, you've got your hospital plan set up. And I'm sure this is a case by case, but is there just a standard like postnatal check-in? Or is that, do you get one of those and if we're all good, we kind of move on? Or what does that system look like?
So each practice is different. At our practice, we really started learning the importance of supporting women a little bit earlier on. So we started having our nurses call our individuals who had delivered around 2 weeks postpartum to do a mood. It was very specifically a mood check. And if there were any concerns with any depression, anxiety, we would bring them in earlier. Otherwise, we would do a 6-week postpartum visit in the office. Again, that's half an hour to address how's breastfeeding going? How are you feeling physically? Do we need to do a pap smear? What's your birth control? And then if there's any mental health concerns, again, it's got to be such a fast assessment. But then after that, that's generally it. And, you know, the prevalence of these mood changes coming up to a year out, it's about 1 in 5 women. I honestly think the rates too are much higher than that because that's women who are willing to seek care, right?
Reported and yeah, absolutely.
Yes, it's incredibly common.
Yeah. So for your new role, is this a role that you play aligning with or in conjunction with a woman's OBGYN? Do you act as that person as well? I know you have the background in that, so I wasn't sure what that looks like now.
Yeah, in my current practice, I'm not doing any OB or gynecology care. I think in an ideal world, I will offer those services, you know, at some point in the future. But right now, I'm really just focusing on the psychiatry piece. I'm still very close to the midwives that I worked with in that practice. So I've already had them reach out about some specific patients, consult about some patients. So it's been really nice to have that working relationship.
Yeah, absolutely. So just staying kind of networking within like community partners and getting your services and name out there to make sure that these doctors and midwives know that this is an option to work with you with their women with the women that they're working with. Sorry, Charlie's over here.
Hi, Charlie.
He was distracting me. Okay, so ideally you would get on board kind of as things start moving along with a female's pregnancy.
Yeah, or like I said, even before, I think a lot of women get a lot of comfort from consulting about potential medication use during pregnancy. I mean, the traditional advice had been don't take anything during pregnancy. I mean, as a midwife, I saw women who were scared to take Tylenol or Tums, and these things have years in-depth research about the safety. So when you talk about a mental health medication, there's a lot of women who are really apprehensive.
Yeah.
It sounds like the full life cycle of this, like, I don't even know if treatment's the appropriate term for it, but best case scenario would be woman or couple decides we want to try to get pregnant, and it happens great for them without help. Maybe they need fertility treatment. you go to a fertility clinic. Best case scenario sounds like the fertility clinic would refer you while going through those treatments to somebody like you. You would go through the treatment, you would go through kind of the therapy and counseling and some of that assistance throughout the process. They get pregnant, then still with you through the pregnancy, kind of measuring and monitoring like that person's mental space. They have the baby still with you. So it's like you're tethered to them the entire time so that they understand what's happening. And I say they, like, from my perspective, obviously I'm not going to be able to have a baby, but I mean, it'd be pretty cool. Probably it'd be complicated, but logistically,
you'd definitely make news.
It would make news.
Tony always said that if he could get pregnant, he would.
Yeah, but I
love that, Tony.
As a partner, there's a lot of unknown also, and like, how do I help this person? And I'm sure those are things that you would also be able to, provide some guidance on.
Absolutely. And this affects the whole family unit. So we don't talk about postpartum depression in the partner, but partners have a postpartum depression rate of 1 in 10 people. Again, I think that number is actually probably higher than what, the statistics say. But postpartum depression for the partner, that's something that exists that we don't talk about.
Yeah, so I do want to come back to that. There were two things that I had thought about earlier that I want to expand on a little bit. So you had mentioned that oftentimes rates of mental health issues tend to become exacerbated after the birth. Can you give a little bit of context, like why is it that we think that happens?
Oh, this is so multifaceted, but I think that this can also give just reassurance to individuals who are going through this. So it's multifactorial. So there's a physiological basis, meaning that as a woman is pregnant, her hormone levels, progesterone, estrogen, a lot of different hormones, they're going to the highest levels they will ever be. And then the placenta delivers and they just flatline. That's a huge physiological change for an individual. So we know that definitely plays a role in postpartum mood disorders. But then you have this huge role shift. You're learning to become a mother. We are more isolated than we've ever been. There's a really great book that goes through the historical context of parenting. But we used to parent in tribes where we had aunts, uncles, grandparents who were all helping us take care of our infants or children. It didn't all fall on two individuals to do this. But now we're in societies where so many of us live away from our parents, from our families. Both partners are working and trying to take care of children. That is so much pressure. It's so much pressure. If the woman's breastfeeding and trying to pump at work, that can be such a challenging journey. So there's so many things. The other big thing with this too is the sleep change. A lot of individuals know it's coming, but to really experience sleep deprivation, it is really hard from a mental health standpoint. So there's a lot of things that can really lead to this. I also think social media and its use has done a great disservice to women and families. I think there's a lot of comparing, there's a lot of shaming, there's a lot of guilt when this experience doesn't look like what it does on Instagram. So I think there's a lot of things in our modern culture and society that really set individuals up for challenges.
Yeah. So it sounds like regardless, if you have an existing issue or not, that it is normal to the change will happen. So it's just to what extent that change will be. And if you have an existing mental health struggle, then with that massive flux in the hormones and just situationally, that's why it impacts it in such an obvious way. Just a combination of all those different variables. Okay, interesting.
Absolutely.
And the other piece that I wanted to get back to before I forgot, and I even wrote it down, which I haven't done this in any of these interviews yet.
Nice.
And I don't want to make it political.
Sure.
But I am interested in the data about something that you said about suicide rates postpartum. Is there any research on suicide rates in women postpartum who acknowledge that they did not want to carry, but they did not have a choice to terminate the pregnancy?
It's a fantastic question.
To my knowledge, I don't know. I wouldn't be surprised if there are some studies out there that potentially look at this, but this is a currently changing field. And I can tell you, even though I'm not in the midwife role currently, I stepped out of that about a year ago. We were already running into really challenging ethical situations that were causing a lot of stress and anxiety for individuals who are making really hard pregnancy choices. So I think will absolutely be correlated. I think that you will see mood disorders related to that, but I don't know that there's any particular studies or data.
Yeah, and I think that's right, because it's a very changing landscape right now. We're also in North Carolina, and I'm not sure, honestly. I know these laws, I think, have recently enough changed. Coming from Illinois, they've all stayed sort of the same. I'm air quoting, but here it's different here as well. And my understanding is this is more like what do we call them? Like a battleground state.
Where
these things are a little bit more up in the air. And I believe it is shifting pretty consistently. So it makes sense that info might not be out yet, but I could absolutely see things leaning that way.
It's a pretty easy connection to make. I just wasn't sure, if there's any data or research currently, and I'm sure there will be if there's not, with the current just political landscape. But that got me curious.
Well, and like Ashli had said, that we're raising children in a much more isolated way now, and what's more isolating than not being able to make a choice for yourself, and then not having support along the way, and then not having support towards that any part of it. And I mean, yeah.
So the support is kind of the glue of this entire thing, like having the support, being connected to someone like you who can help walk them through this process. When you have somebody who is struggling with depression or anxiety during pregnancy, what can you talk about as far as how that can actually affect the child, like the mom dealing with those things?
I think that's such a great question, and that is something that we're starting to get some really important research about. So what we know now is that unaddressed postpartum anxiety and depression, it really puts the body into a fight or flight state. So we see higher levels of cortisol, which produces inflammation. So I think all of us are aware at this point that chronic stress, it can lead to things like heart disease, diabetes, but we're also seeing really poor outcomes in pregnancy because of this. So we see correlations with depression, anxiety during pregnancy with things like preterm birth. The babies don't grow as well. There has been a really interesting new study where they actually did MRIs on the developing fetuses' brains in women who had anxiety and depression. And they're seeing brain changes in infants of women who have depression and anxiety. So they're seeing the structures like the hippocampus, the amygdala. They're seeing a decreased volume in these brain structures. They then went on to study at 18 months. Okay, so we're seeing these changes. Does that correlate to anything? Does that correlate to quality of life, or does it correlate to behavioral changes? And they saw that these children that they followed weren't meeting developmental milestones as quickly as other children. This, again, it's still relatively new. Some of the sample sizes were relatively small, but I do think it speaks volumes to that. Our bodies are connected. All these systems are connected. And if we have unaddressed anxiety, depression, it really affects everything.
Yeah.
I think it can also affect the attachment and the connection that a parent has with the child. Yeah.
Absolutely.
So is it pick the least worst option? Like if you've got somebody, I mean, I'd imagine a best case scenario again would be someone who was intentionally trying to get pregnant would seek out some guidance and assistance from a counselor, a psychologist, psychiatrist. And if they had known unaddressed depression, anxiety, that the the guidance would hopefully be, hey, let's try to get a control of this first, and then like move into this, because it's probably much easier to manage without all the hormonal craziness that's going on internally. So maybe try to get a little bit of a control under the situation before they get pregnant. But if they don't, then what are the options while they are? Because it's take medication, but that could also potentially impact the baby. So which is kind of the best case scenario there?
Yeah, so I'll give a huge plug for Massachusetts General, their psychiatry department. They have done so much advocating and research when it comes to perinatal psychiatry. They do the drug registry. So if a woman is on a medication during pregnancy, it's such a wonderful idea to get set up with this registry, because this is how we're getting data about the safety of medications. But we know SSRIs have been around for so long. So this is your selective serotonin reuptake inhibitors. These are things like Prozac. Zoloft particularly has the most research during pregnancy and postpartum. Is things like Lexapro. These drugs have been around forever, and they have a ton of research about the safety during pregnancy. So when you look at the risk of untreated depression and anxiety versus the risk of a medication exposure, the risk of untreated depression and anxiety way outweighs the risk of taking an SSRI during pregnancy. Really, the risk of SSRIs, it's really low, like no potential teratogen or like malformations, meaning like no changes in the baby's physical structure. Like you think about things like cleft palate or heart changes. We don't see any of that with SSRIs. There's a couple things postpartum, like maybe a short withdrawal period for the baby. That's been called into question, but really overall, they're very safe.
Wow. Okay. What you said there was really interesting. And that's kind of what I was getting at initially, of wondering, is it more dangerous or potentially more dangerous to have an untreated anxiety, depression issue in the mother versus a managed and treated with medication? And it sounds like treat it with medication. There's a lot of research that supports that being better.
Absolutely. And even medications that we used to really stay away from, specifically things for like bipolar disorder, like lithium or atypical antipsychotics. Those are things like Abilify or Seroquel. Those are things that women used to be advised not to take. But the research that's coming out, again, the risk of a manic episode or a depressive episode during pregnancy far outweighs the risk of these medications. It's not to say that there's no risk with these. This is something that you would want to consult with a provider about. But again, when we weigh the risk and benefits, it's almost always going to be to continue the medication.
Interesting.
Yeah. And I have heard just of friends of mine have a similar fear of, well, I can't take it. And it's with things like Tylenol, like you said, or I'm not sure what I'm going to do. I take Adderall every day. Like, what do I do when I get pregnant? Like I've been on that for 20 years. So it's really interesting to hear. And I have heard a lot of them just, I'm going cold turkey. And there's a lot of, backsliding with that, but those are different, obviously, than our anxiety and our depression meds. But it's kind of an interesting spectrum.
Yeah. And it really should be a collaborative decision. I want to make sure that people have the information and that they're not just stopping medications because of something that they've potentially seen on social media or read, because some of the information just isn't updated about this. Yeah. And even if a woman does decide to completely stop her medications, a lot of times just stopping it completely without maybe slowly stopping it, that can have really big implications too.
Yeah. Do you think that viewpoint or that mindset is pretty well across the board within the medical field? Or do you think that there are still some doctors that are kind of hands off with that info?
Yeah, I think I still see providers who tell women they need to stop all their medications during pregnancy, which is really challenging. So yeah, I think definitely within the medical field too. I mean, I spoke of my own journey of knowing that I needed more education in this. I do think, again, just because it has such impact and we're starting to see the correlation of these changes with the baby and then with the postpartum mortality rates, I think it's something that more people are becoming aware of, but it's definitely, I think a lot of us need more education about it.
Yeah, I think about my own sex ed or health education, and I truly, Ashley, I think I've learned more about my body than I did in the last 20 years, just with the information is just not given to you, and you don't really learn it along the way unless you keep having those conversations. Even providers or gynecologists that I've had in the past, there's not a lot of education that goes along the way. It's here's a contraceptive and good luck out there.
Yeah.
And so it's hard to kind of trust how much you know, knowing that you don't know a lot along the way, and then finding the right people to trust to ask those really hard questions too.
Absolutely. And finding a provider who's open to it. I mean, you're going to know very shortly within meeting a provider if you're going to be comfortable enough. It's a very vulnerable thing to talk about sexual health, to talk about reproductive health, to talk about mental health. All of those things are really hard to broach with someone that you've just met. So I think the relationship with the provider too, that's a huge piece of that.
Is it normal, or is it hopefully becoming more normalized for a provider to recognize their gap in knowledge in this area? So for them to say, like, here is where I will be able to help you. I am not able to help in some of these areas where you have some really fascinating and great relevant questions. I think you should see this person, you. Like, is that something that's pretty standard at this point?
I think a lot of us do recognize it. It's a matter of having the resources, though.
Yeah.
We're lucky in North Carolina. We have one of the only postpartum units, like a full hospital unit that's dedicated to postpartum mood disorders at UNC Chapel Hill. So we do have some good resources in the state, but if you're in a rural, small town, being able to find someone who's knowledgeable in this, it may be really challenging.
Yeah, it's difficult.
Yeah.
But also very helpful to understand, like, they're not alone, and the resource doesn't exist not because most people don't need it. It doesn't exist because most people don't realize that everybody does need it. So we're getting there. We're playing catch up.
We are, and there's some really amazing resources that are available. There's an organization called Postpartum Support International. They have support groups that you can access for free, and it covers the whole scope. So they have like postpartum OCD support groups, postpartum anxiety. They have pregnancy support groups. So anyone who feels like they're not supported or don't have resources, highly recommend that resource.
Cool. We'll drop that.
Yeah, that's fantastic.
The so there was a couple of things, and did you have any more questions on that? Because I didn't want to get us on something else.
I'm still aligning my thoughts and my
There's
plans.
so many questions I had. You had mentioned when you said contraceptive, this question popped into my head. With women being on contraceptives for their entire adult lives, and then they want to get pregnant and they have to get off of it.
Adolescent into adult life.
Right. Yeah. Like, what are some of the things that women should prepare for? Because I'd imagine hormonally that's got to be like two very different types of experiences, or at least for some people. So do you see issues with when women come off contraceptives and what that does to them?
I would actually say I see more of the inverse of that. Some women, the way that we metabolize estrogen and birth control pills or progestin can cause some mental health changes, some correlations to depression. That's not everybody, and it's not every form of birth control. Coming off of birth control, I don't know that I see as many changes. In most birth control methods, fertility is going to return pretty much as soon as you stop it. The only exception to that is Depo-Provera, which is the birth control shot. Sometimes it can take up to 6 months for fertility to return to what its baseline would be. But all other forms of birth control, as soon as you stop them, it's
Good luck.
Free game. Yeah.
Yeah.
Okay.
Well, and that was a question that I had with my own gynecologist when you and I started dating. So I have an IUD, and I think I learned more about that IUD in year 4 of
Wow.
it being inside of my body than I did before I decided to get it, because I ended up asking other questions like, if I was to take this out, like how long should I expect before things kind of get back into a typical cycle? And then I said, well, hold on, how many different ways does this prevent pregnancy? And I learned so much in that time, and I'm like, I had no idea that this was what it was doing the whole time.
Sure. And I think the way in this country that we view pregnancy and birth, it's really kind of skewed. Like I see other cultures where pregnancy and birth is viewed as a normal part of the woman's life cycle or the family's life cycle if they choose to pursue pregnancy. But there's not as much fear around childbirth. I think that alone, too, can really have impacts from mental health because so many of us don't have a realistic understanding of what this process even looks like. I mean, you're talking about sex education and where we even get this information. There's so little that we get. What we see on media, it's completely unrealistic. Like what you see is like a woman starts having contractions, screams a bunch of times, water breaks, and like a baby flies out. That's not how the process goes.
How I envision it, truly.
Unfortunately, I got more realistic exposure to it. And when I was in not eighth grade, when I was in 7th grade, my biology teacher, Mr. Corwin, he would put in the VHS, and he does this every year, and it was of an actual birth.
That's amazing.
So, woman wakes up, actual birth, and he would play it, and all the 7th graders are like, "Oh my god!" And then he'll stop it, and he rewinds it. And on VHS, you could see it when it's rewinding. And he said, "And if you don't like it, you can put it right back in." And then he would rewind the video. But that was a pretty memorable experience to learn, what that actually involves and looks like. But
yeah, that's amazing.
And I'm glad you got that. I didn't get that.
No.
I am seeing, I guess just since moving here, and maybe it's just the group that we're in, but I had never had a conversation about a midwife before in Illinois. And again, maybe it's because the friends that we have and kind of the paths that they have taken, that it's more prominent in these kinds of spaces. But it seems new to me. Again, I'm air quoting new. I'm also seeing a lot more with home births and just different birth plans and things like that. So I have a very fearful idea of what birth looks like, and then I'm seeing this be in conversations that are so calm and collective and supportive and collaborative, and the fear that comes along with birth doesn't seem as prominent when it's in a home birth and you are surrounded by women and you're in a natural place and you've done a lot of like emotional and mental work to get yourself to a position to be there. I mean, it's kind of a shifting perspective.
It is. And I think you hit such a crucial point that support is so key during pregnancy and postpartum for the mental health, of course, but then also the birth process. There's been some big pendulums as far as obstetrical history. Like midwives used to provide the majority of obstetrical care in this country, and home births were the primary way that we had our babies. And then in the 1950s, there was a big push to move birth into the hospitals. And like our grandmothers went through twilight birth, which was terrible. They drugged women. They were still awake. They still felt everything, but it was like a drug that made you forget the whole process. Just terrible. And so now you see women who are coming out of that, like our mothers' experiences or grandmothers' experiences, who have a very steadfast view that they want births to be more supported. And I think if you find the right provider, I would really encourage everyone, as you're considering how you're going to go about the birth experience to be really thoughtful about picking your provider. I think a huge component is trauma-informed care. I think one of you guys touched on earlier, if you have a history of trauma, trauma lives in the body and it can absolutely be triggered in a really substantial way during pregnancy and postpartum, especially if there's any sexual trauma. So there's some training that providers can do of having a trauma-informed approach that makes a huge difference in supporting women and how they feel during the process.
That's really good to hear.
Yeah. So this is a great way and a spot to end, but I want to bring it back to probably how I should have started it. And it's
Yeah.
because you mentioned infertility. We
Mhm.
won't go down a whole rabbit hole on it, but I am curious. I know a lot of people, both very close to me and, maybe one or two circles removed, that are going through some type of infertility treatment. Is it just this time in my life that I'm hearing about it so much more, or is it accurate that it feels like this is much more common than it has ever been? Like, is the science just advancing and now this is available to more people, or what's the story with that?
Yeah,
Help
so
me out.
a lot of things have changed. We've started having babies later in life, which is just
Okay.
the fact that as we get older, our fertility decreases. Our general health of the population has gone down over time, so more obesity, more chronic health conditions, that affects our fertility as well. And then there's things that we're exposed to that likely are affecting our endocrine health. So, like the microplastics you hear about, there's things in our food and other exposures that likely affect our endocrine system. I don't want to go too far down that rabbit hole. I don't have great data about that, but I do think that there are definitely several different factors that affect fertility rates and what we're seeing over time.
So when people are trying to go through that treatment, and just again from the people that I have in my life that have been through it successfully and some not, the toll it takes on their marriages or their relationships, on them both individually. I mean, I've seen it where the man wants so desperately to have a family and for his wife to get pregnant, and the wife is more indifferent, but the wife is still affected and impacted when it's not successful, but then the man is also like, so it's this whole like, it's a kind of just a shitstorm of mental health issues that if the couple is not able to ever get pregnant, like, have you seen successful advancements in the mental health treatment for that very particular challenge that can help couples overcome that stress?
Yeah, absolutely. So I think it's again having practitioners that are aware of the process and how challenging it can be. I mean, you hit on so many of the things. It's this hope, but then it puts pressure on the relationship, like timed intercourse. There's nothing romantic or fun about that. And that's so much pressure. And then if it's, part of infertility could be miscarriages. That's a really devastating thing to go through. And if you've had more than one, that's really hard. So yeah, there's a lot of different challenges that can present with that. But I think having providers that are aware, there's a lot of therapists now too. That's a huge part of this puzzle too, that I don't think that we've hit on as much. Like with the psychiatry piece, I'm more focused on the medication. And of course, there's different therapeutic, things that we can talk about, but having a therapist who also understands this is a big piece. And we are fortunate in our community. We do have a lot of therapists here who have done additional training in pregnancy, postpartum, and infertility.
Mm-hmm.
But what would you suggest, just as a best practice for getting them through that process, pre, during, and post, in the most successful way?
Yeah, so I think if you're fortunate enough to have different providers to choose from in your community, doing research about how you're going to feel best supported during pregnancy, whether it be with an obstetrician or a midwife, I would really look into your providers. I think sometimes we just choose people, but I think that can make a really big difference in the pregnancy and postpartum journey. And then I think having a really concrete plan for the postpartum journey is really important. So, talking to your partner about what support looks like. I think having a sleep plan in place can be really important. So, like my partner and I, what we did, he would wake up when she cried, he would bring the baby to me, I would breastfeed, and then he would go put her back to sleep so that it was equal sharing of not just the woman waking up every 2 to 3 hours. And then giving each other, if you can, dedicated nights of getting sleep, because that's a huge, huge part of that journey. I would also make sure that you have a lot of support postpartum. So if you're not close to family, you and your partner come up with a plan of we're going to find potentially a nanny or a babysitter that we trust and make sure that we have additional support because you're going to need it. And that's a huge part of feeling really supported postpartum. And then knowing the signs of what postpartum depression, postpartum anxiety looks like, when to seek help, that's a really big part of it too.
Can you actually just share just what those signs look like, the major ones?
Absolutely. So in some ways, it can mimic traditional major depressive disorder, and that you may feel sadness most days, really overwhelmed most days. You may not feel like doing the things that you normally do to give you joy. That can be a hard thing to balance because you have this new role and may not be able to engage in these things from a time perspective. But it can feel like really low energy, really low motivation. Bonding with the baby can be a really big indicator that something is going on, just not feeling as connected to the baby, not wanting to bond as much. Like I said, postpartum OCD is something that can come up, and we're already in the postpartum state more hypervigilant than what we would be otherwise. It has a good evolutionary basis that we're extra protective of this little baby. But some of those tendencies can lead to OCD. So I've seen women who will start over checking, like that the baby's breathing at nighttime. I've had women who have like set up 4 pallets beside the crib and will like wake up like every half hour to check on the baby. Sometimes women can have intrusive thoughts of like, what if I threw my baby down the stairs? Those are actually pretty common, but sometimes they can start getting into loops. Yeah, and causing distress. Yeah, not the throws. Yeah.
Okay.
That's interesting too, because we just talked with someone about OCD and specifically of those intrusive, disturbing thoughts. And it's I think what he had said is it's less I'm going to do this. It's, well, what if I did? Like what how could I get there? What would happen? That makes me feel horrible. So it's that.
And then self-judgment for how the hell did I even think of that?
Yes. Yeah, and then having to go and well, not having to, but having the bravery to go and tell someone that this is going on. That's a really scary thing to do.
Absolutely.
He actually, I'm glad you brought that up, because he also talked about that is an emerging area of research in OCD because they don't have as much data, because people didn't feel safe to come forward and say, like, hey, I'm having thoughts that I just watched a movie about a serial killer, and now I'm terrified that maybe I could also be a serial killer. Well, have you ever killed anybody? Well, no, I'm just worried that I could. So he said people just thought they were so marooned for having these thoughts and scared of what people may think. And now they're finding like these are very common amongst people that struggle and suffer with OCD. So it makes sense that it would kind of show up with postpartum as well.
Other big triggers to look out for, the sleep portion. I think most people with that transition are totally sleep deprived, but you'll find some individuals, if the anxiety is really ramping up, that aren't able to sleep when they finally have the chance. So that's a huge thing to look out for. I think our partners too, if you have a supportive partner, are pretty have the spidey senses, that like something is off outside of just this big transition. We're both tired, but my partner isn't like themselves.
So I guess that my question would be, and maybe that's where we rely on like the mirror of our partner, is when is enough enough? Like when is it too much? And I think that's obviously probably a case by case, but how limiting does it have to feel before we say, holy shit, I need some help?
Absolutely. And I can't tell you the number of women who came back to see me, like maybe it was just their yearly exam, like for pap smear or birth control consult, who would say, you know what, I was terribly anxious and depressed that whole first year, but I was so in it that it's hard to see out of it.
Yeah.
Because I think, especially again, if you're working, like you just get in this grind of taking care of this baby, trying to maintain yourself professionally. Like I said, if you're breastfeeding, that's a whole journey too. So I think a lot of women, it's hard to even realize how substantial it is because so much changed at once that as time goes on and you start to feel better as some of these hormonal, there's a little bit more hormonal stability. You start to become more comfortable in the mother role, that it can start to become apparent of like, man, I was in a really hard space and didn't even recognize it.
Yeah. Well, and the potential guilt of pausing and looking inward when we've had a huge identity shift, and this whole new role that we've taken on is a selfless one to help support and keep this other thing alive. And how can I pause and look and care for myself in a way that takes away from partner or work or baby, right? It's hard to know to pause and look inward.
Absolutely. And I think that's another huge piece of the postpartum plan is having some non-negotiables of I have to have time this many times a week to go exercise, or I have to have time at least once every 2 weeks to get out of the house by myself to still have my own identity and to support my mental health. I think that's a great thing for individuals to do during the pregnancy is to really be conscious about how am I going to feel best supported through this postpartum journey.
Yeah, and kind of going back to what we talked about earlier of like people don't know what they don't know. So if you have the opportunity and luxury where you plan this out and you have an incredibly supportive system and a partner and everything else, learning these skills of self-regulation and being able to be present with yourself and aware of when you feel off and what you need and how to get there and developing all of those before you have a baby, and so you can deal with it during and after a little bit easier, and it comes a little bit more naturally because you've already worked on those skills. I'd imagine
Absolutely.
so it's I mean this has been there's a lot there's so much to it.
Yeah.
Most of this was brand new for me. But it's I think that it sounds like what I'm hearing from you is the theme is if you have access and you have the luxury, unfortunately, is what it does take to have access to somebody like you in the mental health field who can assist with that very specific part of your journey. Seek it out early and often and stay with it throughout the process because you're not alone. It sounds like most people deal with this in some capacity.
Yes, absolutely. And just a lot of providers too, with the pandemic and the shift, are providing telehealth. So this, even if it isn't in your geographical location, Google perinatal psychiatrist, perinatal therapist, and I can guarantee you'll find a provider who is accepting telehealth consultations.
Absolutely. Yeah. And that's been one of the only positives that have come from the pandemic is this access to not just mental health care, but just care virtually. And this is huge for those rural areas too that live in a really small town where everybody kind of knows everybody, and you can kind of get a reach outside to get a different perspective and different support.
Yeah.
Down?
Ashley, thank you so much. This was awesome. Tons of great information. You made some references to, you actually didn't mention the book at the beginning. I can get that from you if you can't remember what.
Yep.
Do you remember which one? What book was it?
You know what? I did make some notes. I think it's called Hunt, Gather, Parent, maybe, but I will send you. Yeah, I have some resources for you that I'll send over.
But thanks so much for taking the time to do this. This was awesome.
Of course. You guys are doing such an awesome thing.
Oh, thanks. We had started back on sort of the missing information that comes along with like when someone starts going into labor and birth, and then we started talking about like the stirrups that women have to put their feet in, and old metal or plastic speculum, and that's what it's called, right? A speculum. Yeah. And so Ashley, if you could just reshare what some of the more trauma-informed practices in those places were.
Yeah, so we were talking, Jen, you were expressing just how uncomfortable gynecological exams can be, and it doesn't have to be this way. So that's again inquiring about your provider of have they been trained in trauma-informed care. So like when I did a pap smear, I almost never use the stirrups. I would ask the individual, do you want to use stirrups or do you not? I would always offer to have the woman self-insert a speculum, and then I always had a mirror in the room if she wanted to look at her internal anatomy and really understand her body and what I'm doing. I mean, most women have no idea what is even going on during a pap smear.
Does that catch them off guard? Because I'd imagine if, Jen, you said that's never happened to you. So does that catch them off guard when you're like, would you like to see a mirror? Would you like to put it in yourself?
It does. You know what? Only in the 7 years that I did it, I only had 2 individuals who self-inserted the speculum. But everyone, I mean, not everyone, but most women then verbalized, even though I don't want to do this, I really appreciate that you gave me the option.
Yeah.
Yeah. Well, and even with the mirror, I'm going to throw a 50% ratio out there, but I imagine at least or around 50% of women have never looked at themselves using a mirror, let alone like their internal anatomy. Yeah.
Mm-hmm.
I've had experiences where my provider will come in, I'll be in a gown, sitting on the chair, and she'll say, oh, we have 2 student doctors with us. I hope you don't mind that they're in here today. And I'm like,
I feel uncomfortable with that, regardless of the purpose of,
And then they pause in the middle of the exam and they say, well, and here's what this means. And I'm like, oh my, and you're there. Like, it's how do you, and talk about trauma informed, like, how do it's fight, flight, or freeze, or fawn, I'm laying there, I'm like, okay, like, there's 3 of you and 1 of me.
Mm-hmm. Yeah. So you should have been asked before you even got undressed if it was okay to have somebody else come in the room.
I assumed that.
Yeah. So, the other piece that I think it's important for women to know is that just as far as pelvic exams go, you should be giving explicit consent. So the way that I approach pelvic exams, there's a lot of information about the medical hierarchy, and it's very paternalistic, and that a lot of providers will come in the room and say, this is what I'm going to do to you. Whereas it should be, do I have permission to do this thing to you? So like when a woman comes into labor, to the labor and delivery unit, normally the first thing we'll do is a cervical exam to see how dilated they are. And the way that I approached it would be, you will let me know you're ready for this exam when you let your legs go out to the side. Whereas a lot of providers will go in and say, I'm going to check your cervix now. And that's a stranger inserting their fingers into a very vulnerable spot. Yeah. And then if at any point the woman showed signs that she was uncomfortable, clenched her legs, that's an automatic stop. Because then if you proceed, in my view, that's the woman taking her consent back. She's saying that she's uncomfortable. I wouldn't be surprised in some of those situations if there is a history of trauma, which can be really triggering. But I've seen other providers in that situation say things like, just relax. And if you have a history of trauma, that's probably what whoever assaulted you may have said at the time. So then that's triggering. You're starting this whole birth process off with trauma being re-triggered. That's a terrible way to go about the process.
Yeah. It's wild. A lot of the stuff you're saying, which has nothing to do, I guess, contextually with what I'm about to introduce, but a lot of the same fundamentals with trauma-informed interviewing, it all comes back to what you're getting at, which is like giving the person autonomy, freedom of choice in the interaction. How do they want to respond, and at what pace and cadence are they going to respond, but letting that be their decision. So little things, instead of saying, tell me about what happened to you, can you tell me about what happened to you? Instead of giving them 1 seat to sit in, give them multiple and let them choose. Like all of these things of just allowing the person to feel as though they have choice when in that type of scenario, like if they were sexually assaulted, the one thing they didn't have was choice. And they probably did hear these things which trigger these memories and these emotions. So the idea, I've actually never really thought about trauma-informed care because all I've thought about is trauma-informed interviewing, but it's all the same thing. It's like, how does trauma affect people, and how can you interact with them in a way that's not going to trigger that trauma?
Absolutely.
It's an interesting and makes sense to do that universally with people, because you have no idea what traumas people have or have not experienced.
Yeah.
Yes.
Well, and we try to teach like consent and autonomy and choice to children. So I find it so interesting that we have, medical providers that are not approaching patients and the people that they're working with in those ways too.
Yeah.
Well, I think it's, when you've seen it done one way and don't know that there's another way to do it. I'm at the hospital that we did our births at. It was a residency program. So you see how the upper residents are teaching the younger residents. And this dynamic of a very paternalistic approach, it's still very prevalent. And I think if we start calling these things what they are, which is really medical assault, of if you're doing a pelvic exam on someone and there's not explicit consent, it's really what's happening. So I think we have to start calling it what it is and really advocating for a trauma-informed approach.
Yeah.
Absolutely.
I mean, they're approaching it from a passive consent of, you're in this room and this is what you must be here for. And so I'm going to just dive right in because we don't have a lot of time here.
Correct.
There's also a lot of assumptions, I feel like, and this happens with like the scenario of what I brought up earlier with like the interview context of talking to a victim of sexual assault and assuming maybe they've been in a situation where someone's asked them hard questions before, where maybe they have, but I guarantee if they have, it wasn't the exact same experience as what they're about to experience. But a lot of times they haven't, and this is their first time. So if it's somebody in an exam like this, for trauma-informed interviewing, it's let me coach them on the front end, let's set their expectations so they know exactly what's going to happen. And they also know if at any point in time they feel uncomfortable, they know they have the freedom of choice to say, hey, listen, I'm uncomfortable. And this is, we're going at their speed, they're driving. We're riding, right? We're here for helping them through that experience. Is that concept kind of shared where you all like educate on the front end, provide them, we want you to feel comfortable. Like if you are uncomfortable, we want you to voice that, and this is at your pace, and we can stop this, exam at any point in time.
Absolutely. I always tell, especially before pelvic exams, is that any point this hurts, this is uncomfortable, you want me to stop what I'm doing, I will absolutely stop the minute you tell me to. I think that's a critical part. It's a critical part of gaining trust with the individual. I mean, you have the privilege of being there during one of the most important times of the individual's life as far as birth goes and labor goes, but it's also an incredibly vulnerable process. I mean, just even the idea of like internal exams, I mean, we'd normally reserve that for our intimate partners, right? And then to have to go in and have a stranger do these very intimate things. I mean, I think in the medical field, we get very jaded and it's just like, why is she not comfortable with this? Like, of course she's not comfortable with this. Who is?
Yeah.
Ugh, gosh, I can't imagine, honestly. The greatest extent that I have had to deal with anything that would be considered invasive, fortunately at this point, is just a standard physical. And that's just like the turn your head and cough experience, which having a grad assistant or someone in there for that is also like really awkward. You're like, doctor says turn your head and cough, and you look, and this like 23-year-old's like looking at you in the eyes. And you're not supposed to make eye contact. What is this? But that's the extent of it, which is nowhere near. So I can't even imagine. Yeah.
I also, when we were talking just a minute ago about if at any point you feel uncomfortable, like, please tell me. Ashli, just knowing you, I know that tell me could be a shift in their body. It could be a like tap on the hand or a tap on the rather not like even it doesn't have to be verbal tell me. And I know that if I'm in an uncomfortable position, knowing that I have a body language way to share with another person, like I'm uncomfortable, I am more likely going to do that than say, stop the exam, I'm uncomfortable.
Absolutely. And I would normally give individuals that feedback of like, you just, you clenched your legs shut. Like that's a response that tells me you're not comfortable. So I'm going to stop and you tell me when you feel comfortable doing this, if you're comfortable at all.
Yeah.
And I really like that concept of giving options for communicating this sense of discomfort, like not just going in and reading the script of, hey, if you're uncomfortable, just let me know. Like that sometimes is just as traumatizing as the conversation where they have to voice stop. So giving
Yes.
them something easy that they can do that is also their decision of, if I like tap my hand or if I look away from, like whatever works for them. That's a really interesting
Have a safe word.
tactic. Yeah. The safe word.
Yeah.
Yeah. Yeah, no, that's good stuff.
Yeah.
All right.
I wish, and I think Tony just said that he learned so much on, this 1 hour conversation, and I'm still learning. But there are parts of me that wish men, or non-identifying women that haven't gone through birthing or pregnancy or trying or just a general gynecological checkup. There's just so much that people don't know.
So much.
And we're not recommending to show up at a gynecologist's office and ask to sit
Yeah.
in. That's not the guidance.
Yeah.
Ask your partner.
Yeah.
Yeah, that would be a trauma-informed approach to
Right.
learning
Yeah.
more.
Hey,
You might get arrested.
yeah, she suggested that I sit in on a few of these, so
Yeah.
here I am.
I do think, can partners sit in on an exam like that?
Absolutely. Yeah, I've had women who feel more comfortable with like earbuds in, who want to listen to like calming music, their partners be there. Yeah, absolutely.
Yeah.
Interesting.
Yeah.
All right. We already closed it out. I'm just gonna patch this in. I'll figure out how. But this was a good part too. So worth it.
Good.
All right. Thanks for joining us on another episode of Tell Us More About That. Don't forget to subscribe on whatever platform it is that you're listening to us on, and also leave us a rating and review.
If you have any topics you would like us to consider, if you have any feedback or commentary, only if it's positive, please visit www.tellusmoreaboutthat.com.
Thanks again for joining in, and we will see you next time.
See ya.